Hi, I'm Dr. Randy Martin, and we're here at EX 2017 talking about exciting times in really mitral and tricuspid valve diagnosis and therapy. We've got a fabulous panel that's going to tell us about the future, I think. Since we had a hard time with the current and the past, we're going to talk about the future. Michael Borger, Professor Borger, who you know is the head of cardiac surgery in Leipzig. Michael, good to see you again.
Thanks, Randy.
David Adams. We try to bring David Adams out, and so he talks about things in a discussion, but David's extremely well known, very thoughtful, and chairman of Cardiothoracic Surgery at Mount Sinai. Good to see you, my friend. Vinay Bapat,
Nice
Dr. Professor, Mr. Bapat, who is now at assistant professor at Columbia. Good to see you.
Good to see you.
Professor Octavio Alfieri from San Rafael Hospital in Milan. Good to see you. So guys, we just had an interesting discussion. We could have kept going. We didn't talk about mechanical versus tissue valve replacement. We can come to that. But where are we in the current transcatheter mitral valve repair status? Okay, so where do we stand? We have clips, and then we have chordal technology, beating heart. Where do we stand? Professor, where do you think we are with the clip technology?
There are about 60 different devices under evaluation at the moment in this percutaneous area. But we have to think that only 5 devices have got CE mark.
Okay.
And these are the mitral clip back from 2008. Then we have the neocorder,
okay.
transcatheter, transapical neocorder. Then we have 3 annuloplasty device. One is the Cardion, which is a kind of indirect annuloplastic, and 2 direct annuloplasty devices, which is the Cardioband and the mitral line. So these are really basically the devices we can use nowadays in Europe.
So, Michael, what do you think? I mean, do we have obviously transcatheter? These are repair techniques, beating hearts. They're primarily transeptal for the clip technology and currently transapical for the chordal replacement. Where do you think we are?
Well, what we know about these devices thus far is that they are very safe. The morbidity and mortality rates for these procedures are low across the board. The problem is we don't really know the effectiveness yet, and that remains to be seen. There are some randomized trials that are ongoing that will hopefully shed a lot more light on this subject. But if these procedures are deemed to be effective, then I think you will see an explosion in the number of them being done. If they're not effective, obviously it'll be the opposite case. It doesn't matter if it's safe. If you're doing a sham procedure, nobody benefits from it, and therefore they'll have a limited future.
David?
Yeah, I think we have to separate these for discussion.
Right.
Let's start with the clip.
That's okay.
Because that's the most established. It actually was obviously based on Octavio's original sort of theories around edge-to-edge repair and using opposing chordal support to correct prolapse, and then now to really try and remodel, I think, leaflets in the annular dimension for ischemic disease. It's become very popular, obviously, in Europe. They're done almost as frequently as open surgery in Germany for the heart failure population. And the United States is obviously ramping up a lot. When you look at the outcomes, that's where we don't know so much. In fact, the outcomes in the TVT registry weren't very good. Almost half the patients had moderate or severe recurrent MR in 1 year. Now, in fairness, and I think this is still a very early strategy. We need to learn which patients could be clipped. I always hear we can clip this, we can clip that, we can clip everything. But there needs to be more of a discussion about, just as we were having before, who's an appropriate clip, who's the ideal clip patient to have a 90% freedom from recurrent MR. And I mean 1+ or less, not 2+, not an artificial endpoint. And I think that's where that technology is going to move. It's clearly here to stay for a subpopulation. We need to define what that population is. And in all fairness, again, to that data set, now we sort of say, you're not a candidate for surgery, we'll try a clip. Do anything. We can't operate, try a clip, because we don't have other technologies like TMVR to offer yet. So I think that better selection will lead to better results, and that will find a place in the armamentarium. I don't know how big a role it's going to have, but I think it will have some role in
Vinny,
well-selected
I'll come back to
patients.
you in just a second.
I
What's-
try to separate this out in 3 ways in my head, as Professor Alfieri said that there are 5 devices. First of all, which we are using in primary MR and which we are using in secondary MR.
Right.
I think that's critical. And I think NeoCord and MitraClip, which is approved actually for degenerative MR, are the ones which take care of primary MR, the others address secondary MR. And the other emphasis is on reduction of MR than elimination of MR. And I think that's where it differs from surgical treatment of mitral regurgitation. Surgical treatment is always based on no MR at the end of some operation. Whether it's repair, replacement, doesn't matter. And that's where I think I struggle a lot in terms of, yes, you can clip, as David said, but the problem is, does the patient benefit? Is there a even quality improvement, survival improvement, and longevity? And I think I probably disagree with David on that, means in a positive way, because there's 1+ MR after every mitral clip to start with. So I think we have to probably, most mitral clips end with still a lot of residual MR. So
Right.
I think that has been the main issue with these technologies, is reduction of MR and not elimination, and how do we assess the benefit?
Yeah, I think that basically there are 2 major limitations of the mitral clip procedure. The first one is the suitability of the patient. The number of patients who can benefit of this is not extremely large. In our experience, about 30% of the patients are not anatomically suitable for a mitral clip procedure. So this is a major
Calcification on the
limitation.
valve and
Yeah.
calcification, all those.
And as was said by many, by the other people today, is certainly the result of the clip are not fantastic, are not optimal, because half of the patient have already had discharge at least 1+ mitral regurgitation, and the other half have 2, 3, or 4+ already at discharge. Then we have also, during the first year, a declining, and the number of patients who treat for 4+ mitral regurgitation, this according to the registries, is increasing.
Well, if you look at what the data that Paul Saraja presented last year about the commercial experience in the States, if you have 3+, 4+ MR recurrence, or you have TR that's
Plus the
significant,
mortality is going up.
you've got horrible outcomes.
Horrible outcomes.
Exactly.
The other problem is what patients and the referring doctors in US want. And it has been one of the biggest issues for at least what I've seen in last 4 months. Patients come for mitral clip. So even if you have a very educated discussion with the patients and the referring physician, sometimes they say, why not try mitral clip? If it fails, you can still operate. So I think this is where I struggle a bit at present in balancing it out with what's right medically and what is wanted by the
as
patient.
opposed to the NeoCord and the other device that's in that area is the Harpoon, of course. We know from experience that you can still re-repair the valve if the
with the
procedure
chordal,
fails.
the neocord and the
Yeah.
Harpoon type procedure,
You can,
correct?
but
MitraClip
I-
is a little difficult.
I think, and that was one of the messages that got out early when MitraClip came out, is that you can re-repair the valve, but those of us who have seen these valves,
no.
it is very
It's
difficult.
very difficult.
So is the chordal replacement currently transapical? So obviously will move transeptally. Is it an excellent technique for for selected cases, P2 prolapse, something like that?
Well, David
You
and I
guys are
are the
co-PIs on
PIs
one of the
for the
trials.
FDA approval trial, but the European experience, principally from Padua, tells us that in so-called cohort A patients, isolated P2 prolapse, that the results are very promising. It is, not in the realm of a prospective trial, and therefore we have to be a little bit cautious in interpretation of the data, but that is the grounds for
You
the
have
randomized trial.
selection. Excuse me. Go ahead.
The data from Padua are showing that reasonably good results are obtained only for P2, because all the rest, when different segment of the posterior segment or anterior segment or Barlow disease, or even worse, when calcification are present, the transapical cord are really failing, and the long-term, relatively
it's very interesting.
Is at 2 years results.
This
have been
discussion
published,
is
are
very
poor.
revealing because you have the MitraClip, which is a panacea in certain countries with a 50% failure rate at 2 years of 3 to 4 plus MR, but the NeoCord, which even in the worst case population, the type C patients, 60% of them were free of MR at 1 year, 40% failure. So, surgeons looked at 40% failure and said we should not do any type C patients, even though it's reversible and very safe, whereas on the MitraClip side, a 50% failure rate is deemed a great success because 50% were treated. So as a specialty, we're going to have to get together and start defining what are the expectations based on risk and population. But I think that the trials will show the benefit or lack thereof of transapical procedures like MitraClip. I personally think there is going to be another well-defined group of patients that can be treated that way, and it is truly minimally invasive. You're not on a heart-lung machine. You have a very small incision, and it's completely reversible. So I think that if we ended up with another 10 or 15% sliver of mitral valve surgery that could be optimally treated that way, that would be well worth all our efforts to do that trial.
Michael, you want to...
I just wanted to say, since the title of this session is then the future, it's also a promising sort of step to what probably, from my point of view, will be the future. Maybe that's 10 years from now, maybe it's only 5 years from now, I don't know. But the first transcatheter annuloplasty combined with a NeoCord procedure was done in Mainz, and the result was very satisfactory. Of course, we're very short term, but this could be a future consideration for higher risk patients with degenerative disease.
I think,
and I don't think it's 10 years away. I think you're right. I think it's going to come quicker.
Using the transapical cord, you have also to consider the patients who are excluded from the procedure because annular dilatation.
Right.
This is a procedure that in the future, if we have to talk about the future, is going to be only in the very early phase of the disease before the annular gets dilated. So this is a typical procedure that has to be done in the early phase of mitral valve regurgitation.
So exciting times there. What about, let's switch topics now and work our way up the controversy or non-controversy chain. Vinny, where do we stand with the concept of transcatheter valve replacement now? So we already talked about that in the previous section, but for valve and ring, where do we stand?
I thought you were going to ask me that question last, but anyway, I'll kick off the controversy. So I think, as you saw that 2 years ago, TMVR technology was introduced and there was a huge amount of excitement because of lots of acquisitions. And rightly so, I think that the whole thing has calmed down now and people are really working hard to make it successful. The early results, I think the efficacy has been shown very well. The proof of principle is there for majority of the devices that if you implant them properly, they work. There are some minor elements in terms of anticoagulation strategy, etc., to be sorted out. The devices are at present large, so most of them are done through transapical approach. So again, there is some morbidity involved in that kind of procedure. So we have to try and make the procedure now repeatable, safe. The advantage of it for sure, as we heard from Michael before, is most repair technologies, they're safe, but probably the efficacy is something we doubt. Here we know definitely the efficacy is there, we have to make it safe. And I think that's where the balance hangs.
But can I just say to that point then, Vinny, the safety is really an issue, but also I would caution a little bit what you said that the long-term effectiveness is not a problem. I think the effectiveness as far as MR is concerned, that's great, that issue is solved, but the thrombosis issue is going to be a real problem. When you look at all of these devices, there is a lot of fabric in areas that are in low flow, blood flow situations, and to me, this is going to be a really tough nut to crack.
So, go ahead.
Another problem, in my clinical practice, I find that the selection of patient
Right.
is very limited, you know. We continue to present patients for this type of procedure because there are no other alternatives, but the majority are turned down for one reason or another. The left ventricular outflow tract obstruction, the type of the annulus is too large, too small, interfering with that, with that. So really in the clinical practice nowadays, certainly the concept is very promising. We are looking for that, but certainly in the clinical practice, the number of patients presently who can benefit of that is very limited, at least in our experience.
David, your thoughts?
Yeah, I think Octavio hit on one of the Achilles heels that it's been challenging so far, which is the outflow tract. And just the anatomic screening, like NeoCord and other technologies, is challenging. And I think that's just, frankly, just also what limited a lot of the MitraClip data in the United States was trying to define those populations. So we're still very early into this. These valve designs will change, and our understanding of this will all improve. And I think and of course, the big target for everyone is ischemic disease.
Correct.
And heart failure. And it just remains to be seen. Remains to be defined what level of evidence we need to actually get the heart failure community to believe treating severe MR is going to matter, because that's the population that's the easiest to put, that's the most appropriate in terms of anatomy for a transcatheter valve. And maybe COAP and other devices will shed some light on it. And I think COAP's going to be interesting in terms of one way or the other helping us sort of think through it, because on the one hand, if it's negative, it may well be because you didn't eliminate the MR, which a transcatheter device can do. If it's positive, I think it will give some momentum to treating MR related to heart failure. So either way, I think exciting times are ahead in that arena.
This is clearly not TAVR.
Yeah, and I just want to re-echo what Octavio said, is that I think the companies need to start thinking a little more along the lines of a design that's something that is going to be able to be applied in a much larger group of patients, and not trying to fit the patients to the design. So we were trying to do a live implant for the Techno College here, and we looked for a patient for a month, and we're not a small center. We did not find a single patient. I know we had the same experience when I was at Columbia, as we were constantly looking for patients, and it is difficult.
Yeah. I think it's we have to change gear here a bit. If I remember correctly, 12 years ago, TAVR was same. We had one size device, and nobody believed in it, and there is a possibility that we are going through the same journey again. And I agree with you, but when you make device iterations, as a surgeon, we would want something to fit everything, but there are some limitations in terms of engineering. And as David has said, we'll understand them, and we'll continue to modify and iterate. And I'm pretty sure what we are seeing is generation 1 devices, and the current emphasis is totally on how to make them safe. And of course, nobody wants to challenge the indications within the realm of understanding today in terms of LVOT, for example. But this is going to get better slowly, and there will be a definite application once, say, it becomes transeptal in patients who are getting MitraClip today, for example. So I think we need to iterate on this in terms of heart failure populations, secondary MR.
I'm just a little bit concerned, because we've been listening to this story for a long time, and I'm starting to remember, xenotransplantation. Xenotransplantation is the future of transplantation and will always be the future. And I'm wondering if we are starting to get to a point where we're realizing there are limitations to our engineering capabilities.
I think it's possibly because our expectations today have come parallel with what the TAVR is today, which I think is probably wrong as well. So look at tricuspid side. Tricuspid side, there are 6 or 7 so-called mature transcatheter devices, but nothing's perfect at present. But
that's a tough
I
story.
think we have to continue to evolve and see what non-surgical patients can get.
So what's the audience take away from the discussion on transcatheter mitral valve replacement? It's evolving, but it's going to evolve at a slower pace.
Yeah, it's a much more difficult population. You took aortic stenosis and you had one lesion,
Right,
basically.
right.
You had calcified leaflets you could land in, and surprisingly, the stroke rates weren't there. I think most surgeons that saw that in the early 2000s all thought all these things we picked out and sucked out all the time were all going to go everywhere, and they didn't. And that's why that field is such an important field, and the people that really had the vision to try that really executed and proved a lot. And I think also, I'll just say, I was talking to Professor Carpente yesterday. I mean, his discovery of development of bioprosthetic tissue we could use really has led now to the treatment of a disease field, not just valve replacement, but really aortic stenosis as we know it. I think sooner than later will essentially all be treated with tissue before we're done. So that's interesting. I think, Randy, what you're going to see in this TMVR or in this mitral field is the recognition that, one, you're inside the heart, so you have different anatomical issues to deal with, including low flow, stagnation, clotting, outflow tract obstruction, and where the anterior leaflet moves.
What do you
all
do
those
with the
things
anterior
happen.
leaflet?
Then you have the diversity of prolapse. Not all P2 prolapse is P2 prolapse, as we discovered in the Everest trial. It's not enough to say P2 prolapse. You have to define the volume and the height and the amount of area of prolapse, the adjacent segments, or you'll still get bad results with technology that's basically single lesion treatment. The transcatheter mitral valve replacement, in terms of end stage, still has the one advantage of is it could treat potentially all lesions if they can sort out the anatomy and the size of these devices, which is, as Michael said, still a very early stage and may be there. We may be talking about this for a while. I do think that chordal resuspension of leaflets, whether that's done now transapically or in the future in some other way that doesn't require an apical incision, is interesting, and particularly this combination Michael mentioned of some sort of annuloplasty device and some resuspension may actually be a very important modality of treatment. It is truly less invasive, and if patients really want less invasive, it's to avoid the heart-lung machine.
Yeah.
Yeah, looking at the future, really, I don't know whether transcatheter mitral valve replacement will replace completely the percutaneous mitral valve repair. In my opinion, these two technologies are going to be parallel and complementary one to the other, because I don't think that even in the future, with the perfectioning of the valves and so on, the replacement will be superior to repair, even percutaneously. I don't see why should be superior. If surgically nowadays mitral valve repair is superior, why should percutaneously replacement be superior to repair?
It won't be, Octavia, that the target population is going to be patients that we've agreed a few minutes ago are appropriate for biological valve replacement. That will be the target. It is, at the end of the day, TMVR is a biological valve replacement. So it will never replace patients that are capable of keeping their own valve. The question is for patients that have a particular pathology or risk cohort that says biological valve replacement is appropriate, will it be as safe as surgery? And of course, even at that mark, it will be demanded by patients to avoid surgery. That will be the real question.
Vinny, you mentioned the tricuspid valve. Where are we with transcatheter therapies? The tricuspid, it's a whole nother animal.
I'm going back to the earlier point, and this is where the tricuspid dilemma is. You have severe TR, but patient's fine, doesn't get operation or referred. Then you suddenly see a patient who has got ascites. And these are very difficult patients to manage. So at present, these are the patients in which some technologies have been tried.
Right, technologies
with
primarily.
50% probably acceptable results, 50% no difference at all. And again, the aim has always been reduction in TR rather than elimination TR. We know that just reducing the TR even by 2 grade from, oh my God, lot of TR to severe TR has been beneficial. A lot of the treatments such as Trialine, Forma, and now Cardioband is coming into annuloplasty. I see them as complementary techniques, and other limitation is a lot of TRs are based with the pacing lead which is causing TR, so it's very hard to know who's it going to benefit and not.
What do you?
Can I mention a little bit there? We had some experience with the Tri-Align. We've also got I think the world's largest experience with tricuspid valve clipping in Leipzig. And I can say these therapies are not extremely effective. There's a lot of TR that's still left over. However, the patients benefit clinically a lot from them. So going from 6+ TR to 4+ TR, you get a large amount of volume redistribution, and they benefit at least in the short term. Whether it's going to be in the long term, that I'm a little more skeptical. But I think the real solution here is to prevent these patients from becoming so late that they're no longer surgical candidates, and that's a combined strategy of being more aggressive at the initial procedure
educating the cardiologist.
And educating the
Really
cardiologist.
educating
We have
the
to push
cardiologist.
that.
Absolutely.
David asked the question before, but it didn't get answered. What do we do with severe TR in a patient that's otherwise doing well? My answer is operate.
You better treat
now.
it. You better treat it. I think
That's true.
But you do get called by cardiologists saying patient has no symptoms and there's no RV dysfunction, and the patient doesn't come to your office for operation. It's a fact. So we have to educate, and I think we are discussing a lot of controversies. And as so to speak, a controversial surgeon here, I always think we discuss TMVR, we discuss this, but we need to engage a bit more, because at present that's where we are lacking.
Yeah, I think that really going back to the percutaneous treatment of tricuspid regurgitation, we are really at the very beginning, because this valve was called the forgotten valve. Actually, is not forgotten anymore. Is a very complex valve, because if you think the regurgitation is almost invariably due to the double component, at least in the patient we are talking about, is annular dilatation, which is asymmetric, and to tethering, which is also asymmetric. In mitral valve, the tethering can be symmetric. In tricuspid valve, is always asymmetric, because the septal leaflet is attaching directly with chordae to the septum. So by definition, the tethering is also asymmetric. So it's very difficult to treat with some devices addressing the annulus. So we should address both things together. This is the reason why are relatively ineffective. The present devices are really relatively ineffective. We should try to address both the tethering and the annulus.
Yeah, I feel another debate point coming from my next stage appearance with Dr. David. I'm sure you guys agree with me that over half the patients that you operate on for severe TR have had previous left-sided surgery, at least half. I mean, that's the most common scenario. And all that should be preventable by a more aggressive strategy up front. I think we're going to talk a lot about it. I remain less convinced of the size of this population that needs to be treated. I think that the left-sided valve disease still is we talk about tricuspid in terms of end-stage tricuspid disease because it's so dramatic. It's really a big problem for the patient, but volume-wise, left-sided valve surgery still dominates.
You're talking about isolated.
Yeah, isolated. I'm saying that
Randy, you're the expert in this area as a
unusual
busy clinical cardiologist. How often do you see patients with asymptomatic severe TR?
It's very uncommon.
Very uncommon.
Yeah.
I mean, everybody, they're symptomatic. They look, but you look at them and their neck veins are up. I mean, it's not at all uncommon.
But the question is, should you treat them sooner? That's what we are discussing, right?
If you're asking me, I'd say yes, because I see these patients later on, and I mean, I think David's right. I've had a lot of patients who had excellent mitral valve repair, and 12 years later, now they've got AFib and they've got torrential TR, and they're reading that it's a 25% mortality if you operate on me. Can I have one of those new transcatheter therapies? So it's a big problem. We got a minute or two. What words?
But I do want to reemphasize something.
Maybe we got more than take that back. We have more than a minute or two.
It's important to emphasize that back to this TR concept. Severe TR is poorly tolerated, and it's our right-sided our liver and kidneys just are not made to function with high venous pressure. So it is possible that there will be an acute benefit from TR reduction that won't translate necessarily into a longer life expectancy, but it is something to think about, and that's again a logic for aggressive early surgery.
So yeah, you're talking quality of life differences that are pretty dramatic. So you guys represent tremendous experience and expertise, both old and young. So what advice
Thank
would
you.
give? I didn't
appreciate
say where
being
you
very
were.
young. Okay.
No, I didn't
It's
put you
fine.
in. I didn't put you.
right.
You're in the tremendous expertise
Okay.
level. I'm not putting you in the old.
Yeah, I
or
just
young.
decided I want to be called Mr. Adams. You sound so smart when you say Mr. Bapat.
I'll call you. I'll call you anything you want to be called if you stop talking for a minute. so what? But I want to ask you this: what words of wisdom would you give to the surgeons today about, what they should do to enhance their surgical skills, and where for mitral and tricuspid disease, and where should they be looking as far as becoming an interventional surgeon? Michael?
Just in general, they should learn some guide wire skills, at least 6 months of dedicated guide wire type of rotation. And I would say that we're going to have to do more and more simulation. We're in desperate need of good simulators because, let's face the facts, we're going to be doing less valve surgery in the future.
Okay, Vinny, what do you think?
Did I hear that correctly? But I think we need to be involved in mitral technology so that we are the best people to judge, I think, whether
Absolutely.
it's correct or whether it's not correct. Because
Absolutely.
there's a lot of pressure at present because TAVR, everybody said is going to fail, but it has become successful. So I think people are sometimes afraid of criticizing a technology. I think we are the people who should be the gatekeepers
would
of
agree.
technology.
Yeah. I think, we many years ago we had that intuition, let's say, to train surgeons in transcatheter technologies. I think that is essential because in the future we have to, the process is going to be maybe a little bit slower for mitral compared with the aortic, but certainly the direction is toward closed heart procedure. So the catheter will be the instrument, let's say, to correct mitral regurgitation and mitral problems and tricuspid problems. So the direction is that. Not only that, but I think that surgeons should be also trained very much in imaging. I think that in the futures, particularly in tricuspid and mitral percutaneous, a very important issue really to be able to interpret the images because, for instance, this device for the annulus or also for the tricuspid, they really require optimal imaging. So I think that is another area where surgeons should be particularly trained in.
So, Mr. Adams?
Thank you.
What are your thoughts? We're gonna finish up with you.
Yeah, Randy, I think that the other idea I'll throw out is that the day of the superstar cardiac surgeon that does all things is coming to a close.
Right, absolutely.
It's just not going to be possible to keep up with all these different fields. And I think one of the other messages for young people is you're going to have to differentiate. Heart transplantation and assist device is going to be a specialty. And ECMO, it's going to be a specialty. Revascularization likely is to be a specialty. And I think that valve therapy will remain to be seen how long there'll be one specialty versus two. We're still going to need open valve surgeons. But I think you're going to have to really declare yourself and get in units and really pursue that dream under very careful guidance, because just being generally trained and going out in the community and banging off a cardiac surgery list is going to go away.
Open valve surgery will be very difficult in the future. We are going to operate, for instance, endocarditis after percutaneous replacement and so on, or things like that. So it will be a very, very tough surgery.
Well, listen, I've enjoyed it. We could sit here for hours, but they're going to get the hook after all of us. I hope that you've enjoyed it, and we appreciate the expert panel. Thanks very much.
Thank you.
Thank you.